this meeting and taking out your time to deliver a very important lecture, which I think is going to benefit everyone who has joined the meeting today. So without taking much of your time, I would request you to kindly proceed with the session. Thank you.
Thank you very much for the invitation. I'm very honored to be here. I hope my English you can understand my English, but feel free to write on the chat if you need that I clarify something. Okay. Well, good morning. Here in Peru, we are at morning. I know that we have different hours, so thank you for being here. Today, I'm going to talk to you about the psychosocial project we've been working on within the framework of the Global Initiative for Childhood Cancer. This project started in Peru, in my country, as the first focal country, and it was planned to serve as a model to other low and middle income countries. So I'm happy to hear all your thoughts, all your feedback, because this project is open to continually improvements. So today I'm going to start to talk to you about just a little about the Global Initiative for Childhood Cancer. So you can see what are the biggest goals of this and how the psychosocial project was developed. Then I'll present the standards that we adapted for our country that were extended later to the region of Latin America and Caribbean, and that can be modeled to other countries, of course. And finally, I'll share some insights and recommendations for implementing these standards so we can discuss improvements, some things that you think that we can add to all these proposals. Okay, as we know, childhood cancer rates differ, the survivors rates are very different in high-income countries and low and middle-income countries. And it responds that of high inequalities that we have in access to health, late diagnosis, high abandonment to treatment. So we have a big challenge here because we can see from here that psychosocial care we don't see it like something that we need to prioritize because we have like bigger goals to achieve. But the thing that we want to think all of us is how psychosocial interventions could help to these results also. So with this this reality to reduce this gap in high-income countries, in low-income countries, in 2018, working collaboratively, WHO, the World Health Organization, with St. Jude Research Hospital, launched the Global Initiative for Childhood Cancer to promote leadership, to promote technical assistance to governments, to prioritize childhood cancer, to improve the quality of care, the access. And we have a technical package to guide all our work. Cure All is like the acronym that represents the most important pillars that guide our work. So the project I'm going to present is contributing to the first pillar, that is centers of excellence, how we can improve psychosocial care in our centers of health so it can be excellent. So as I told you, this project began in Peru. Peru was the first focal country, and we had the primary objective to developing a framework for implementing and evaluating psychosocial care standards, and that this could serve as a model to other low and middle income countries. We based our work in previous evidence. There were a lot of marvelous work that were made, for example, for the Psychosocial Committee from SIOP, and also all the work led by Lori Wiener and her team with the support of Matthew Miracle also, that established different recommendations and standards that should guide our work. So we started this project with the support by PAHO, of course, Childhood Cancer International, and La Fundación La Roche-Posay, and we conduct a national situational analysis in Peru. We had 25 professionals from 9 of the 11 existing at the time institutions that were treating childhood cancer patients. We had also the participation of 104 caregivers in a survey. We had interviews, we had several meetings to think about not only the results, how we were of the services that the previous standards recommended, but also to think what should be more important to take into account in our centers. Because we needed to prioritize based on the needs we identified, but also the recognition of the resources we had available. In most of our institutions, there is only one psychologist, for example, in Peru. Now, there are a little more, but in a lot of institutions, especially outside Lima, there is only one psychologist for all the institutions. So it's very difficult to take care appropriately, and of course, taking care of that professional of health. So we discussed this information, we discussed the findings that show us that the services were developing according to these standards. And we developed and validated a proposal. We saw what were the most important things that professionals, that families say that we needed to take care of. We had a think tank meeting with more than 50 professionals from all over the country. We have several meetings, and we validated these standards that I'm going to present in a little while. And something I want to mention is that I found a group of very committed professionals. When we ended the think tank meeting, almost all, 97%, reported they wanted to keep working with this. So we established, it wasn't planned in this project, but we established 5 multi-center groups for one of each of the first 5 standards to think how can we improve attention according to this standard and develop materials that doesn't need so much resources, money, but only all the wisdom, all the experience that this professional have. Okay, so before presenting the standards, I want to share some important thoughts to help you understand the proposal, how we are thinking about it. I've always heard from other specialists, even specialists that have worked in different standards, if we should call it standards. Because when we think about standards, especially in resource-limited context, it can usually seems like those goals you can reach is something that is very far away, that and it's like these check boxes you have to check, you have to do, but you get tired in the way, you get frustrated, and with limited resources, you give up. Yeah. So during our analysis, as I told you, we identified that there were a lot of professionals very committed with their work, but all the work they were making wasn't documented or in their institutional plan, wasn't even in their role function, the things that they should do in their work. So most of the times wasn't recognized for the authorities, for all the work they've been making. And also, for example, some colleagues told us that they were told that playing with patients was like a waste of time. They should really work in work that really matters. Playing is not. And we know as a psychologist or as we professionals that work with children, that play is the most important tool to communicate with them. Another colleague told us, for example, that when she asks for materials, papers, colors to draw, to help a child to understand the diagnosis, the treatment, they told her that the hospital wasn't a school, so they shouldn't have those materials. So what did those professionals did? They spend more hours of their work. They use their own resources to bring the materials to intervene. So it doesn't matter how loable it could be, but if you think about it, these professionals are doing a lot, but it can be something continuous, yeah, because that professional is, of course, is going to be frustrated if the people doesn't recognize their work. It's going to be tired. It's going to be in risk of burnout. So we lost here, no? So they experienced high level of stress, and that was the thing that amazed me the most, because they were very committed, but they were like in at a very risk of really having burnout. So in this proposal, we invite you to view standards more like a guiding horizon, not as a mountain we have to climb, and it's very difficult, and we have a lot of weight above us, but as a path we can build together, seeing, of course, a big goal. Yeah. So all the pieces that we should have for consideration is we have to establish our goals. Not only what we need to do, but for my institution, for the reality of the patients I see, and the resources I have, what can be our goals for short-term time, for medium-term or large-term. And one thing that is very important, and I'm going to recommend a lot, is that a lot of good work is already being done, but it hasn't been documented enough. So even in low and middle income countries, there are a lot of efforts that professionals are making right now, but they are like, when we don't have it documented, we can't prove how important it can be. So a recommendation I want to give you all for the start is that each step we can take, each little intervention, even if we think it's very small, we have to document it. What was the need that the needs you detected to see that this intervention was important? What framework do you based on to proceed to this intervention? And how can you evaluate the impact of this? How can you involve some other healthcare professional suites to make a more interdisciplinary work? Yeah. So we are going to talk about in this new view of standards. So I'm happy to hear all your thoughts about it. Okay, after all these surveys, these meetings, the revision of materials, we established 6 standards of care. We called it that they are an adapted version of previous standard, because they are based on all the big evidence that support that these are very important things. We have the theoretical and practical evidence from international experts, but also the things that we saw in our country and later in our region in Latin America and Caribbean. So this 6 standard, the first 4 describes what are the services that pediatric cancer patients and their families should have access to. We are going to speak, I'm going to explain a little bit of each one of them, but I'm going to name it first. The services that pediatric cancer and their families should have access to are psychosocial assessment, psychoeducational support through the course of all the disease and treatment, mental health attention, resources for a gradual return into daily life, and support for survivors, of course. Then, only this can be possible if we take care of the team competencies and the team self-care and care as a team. So we also include that as an important part of these standards. And all the care, not only the psychosocial care actually, but it was here, is that we need to have some approaches that guide us to make a more accessible, more respectful attention. And actually, this sixth standard was like the newest one we found out. It's not new information, but it should be highlighted to that we all can consider it for all the interventions we have. So I'm going to explain a little of each standard, some of the findings we have in Peru, so maybe you can know how it was, how we begin to think of all this. Well, actually, now we are running a regional situational analysis in Latin America and Caribbean. Well, when we have all the findings, we can see how I can share it with you. So the first standard, we are going to see the description of the standard, but also like the biggest goal we want to achieve. So that when I told you that you have like the horizon that should guide us, well, this should be. The first standard established that all children and adolescents with cancers, along with their families, should undergo psychosocial and financial assessments that provide healthcare team with the necessary information to apply an holistic approach focused on well-being, adjustment to the disease process, and treatment adherence. So we want to ensure timely care through the early identification of psychosocial needs, psychosocial risks, for example, for abandonment of treatment, for adjustment to illness, and of course, identify also the protective factors for this. So here are some findings we had in Peru. We found that a lot of a potential risk for treatment abandonment and also psychosocial adjustment. Not only the quantitative ones, we can see a lot of them reported economic difficulties, more than half that they have to move to another city for treatment. That is very common. And they had to leave work, they had to resign or ask for permissions. And they also mentioned, even if you can see maybe it's not that high, the number, but it's very important because actually my country is very, very usual. So the violence, sometimes we in medical care don't include those things like big stressful events that we should take into account. 68% mentioned, caregivers mentioned they didn't recall being assessed about these needs. In qualitative information, they also report distress, fear, lack of social support, coping difficulties. So this is very important to take into account. The things we are prioritizing in psychosocial assessment were previous said and well very documented in previous international standards. And also when we have different meetings with health professionals, they support all this information, saying that psychosocial information that usually was collected by psychologists, by social workers, is frequently missing from clinical history. So even if it is assessed, it not only the professional that assess that needs have access to see it. So that can be a big obstacle to have like a comprehensive care about all these needs. So this information is poorly integrated in treatment plans, in how they communicate to the families. So that is very important to notice. They recognize also that early identification may allow all the health team to intervene a timely manner to prevent not only mental health comorbidities and treatment abandonment. So when we need to prove how important it is to take care of psychosocial aspects, it's important that we also see these big indicators, big results that are expected in public health or in the medical setting. So we can work as a team. Sometimes psychosocial things seem like an extra that is separated. Some recommendation. There's a lot of information that we are collecting. Most of them is in Spanish, so we are translating it. Is some activities that we should take into account. So it's suggested that all the families should have at least one psychosocial and financial assessment at the beginning of the treatment. But in the best of the cases, have regular ones. So we can see how this progress or how the intervention maybe we are making, they are being effective. As I told before, the documentation of psychosocial and financial information in medical history is very important. And also, we know that the lack of resources, of human resources on all the services, make very difficult to attend all their needs. So it's important to have like a list, different alliances to make referrals to specialized services that when they are needed. There are a lot of needs that can be held by the professionals in the institution, in the hospital. But maybe if we can promote more alliances with organizations of health, with different community agents, we can improve the quality of care we are giving and have interventions that are on time. Something very important is when you think a way to assess all these needs, considering all your resources, the services that you can offer, we have to make sure that we have a way to respond to the results of this assessment, because we need to take care of that family. If we assess and know and don't integrate it with later care, we can be iatrogenic. We can like let pop up important need, vulnerability, and it make it that the family can be more endangered, more in risk, more at risk to abandonment treatment, adjustment, etc. Please tell me if there are things you can follow to, I can repeat or I can explain more. Some things we already know is the marvelous work and KSAC, for example, did with a pediatric psychosocial preventative health model. They developed the psychosocial assessment tool for assessing family risk levels, and it's a very organized theoretical and practical model that could allow us to know what are the principal needs and how we respond. But we found in Latin America and other low and middle income countries that sometimes it's difficult to assess with some standardized instruments because it has to be validated in the countries, and some countries are validated, for example, the PAT. But some things that something that's very important is that the professionals are already making a lot of efforts to identify these needs. They recall using not only interviews, but also, for example, creating some new service, some checklist that can allow them to identify what are the principal needs. For example, if you remember when I told you that we established 5 multi-center groups in Peru, we had the group for the first standard that designed a tool to assess in a short time, and that different professionals could assess it, like the principal things that could be risks for abandonment of treatment. And we had the support for the Ministry of Health, the unit, the Direction of Cancer, the DPCAN, to run a pilot of this instrument. And we now have the feedback. Actually, we need to incorporate more psychological factors. We need to precise more what are the services or the intervention we are going to offer later. But it's a big achievement that we could make that alliance, and we can think of instruments that were created according to the necessities of the institutions we have here. So if you have an information, like a survey or a checkbox, something that make you can assess the needs, it's important you also validate it. So, and you can define what are the next steps with this information. What can we do with this information? Okay, the second standard is called psychoeducational support throughout the course of the disease and treatment. It's planned to do through all the process of the illness and treatment. And it established that children and adolescents with cancer and their families should have access to psychoeducational and supportive resources like not only intervention, but materials. That is very important because sometimes there is a lack of human resources, but we can have some materials that can help families or other professionals that are not specialists to explain some things. And the aim is to facilitate the understanding of the children and the families and help them to manage the emotional the emotions that emerge from all the experience. So what we want to achieve, we want to they have an increased sense of control and reduce psychological distress during illness challenges. So this is an specialized intervention in mental health. This actually can be implemented by different professionals. All these standards, actually, there's one thing I forgot to tell you. Of course, it has a leadership of psychologists, of social workers, of special child specialists. But it's important that all the interdisciplinary team get committed to this. Okay. Yeah, because each of these, for example, the psychoeducation correctly given, it can be by nurses, by other specialists, and then engage with further and more profound interventions that can be doing by a psychologist, for example. So what we found in Peru, I'm not bringing all the information, but two things that I think it will be important to know is that they recall the need for orientation and support in two biggest issues. To manage the side effects from their patient treatment and to understand what was the diagnosis and what consists the treatment. So that was were the biggest needs. This psychoeducational support is also alignment with international standards, and health professionals perceive that when the patients and the families are informed, they adjust better and contribute to treatment. So not only the evidence, the documented evidences say that, but also the experience from health professionals. So information is an important tool, not the only one, but a very important tool to adjust, to understand, to collaborate, to be more adherent to treatment also. Also, they emphasize that protocols and guidelines for specific procedures or moments of the treatment are required, and they need to incorporate an interdisciplinary approach. When we are talking about moments of treatment, we also talk about transitions. For example, not only is the diagnosis, but is, for example, when the child get hospitalized. Yeah, in hospitalization, they have to adjust to all the things that are involved in hospitalization. So it's like a transition that we can prepare the patient, the family, to make it better. So some recommendations are to develop different interventions and materials that can help to these things. Understanding the diagnosis and the treatment, we now have a lot of materials. This is, I don't know if you know the Angus Olsen, I Draw Childhood Cancer. He has a lot of graphic materials that you can get it online. So there's a lot of information already available. So we can introduce it, we can include it in our interventions. Of course, it's very important to prepare for invasive procedures, not only information, but also the support for all the emotions that can be involved. And as I told you before, adapting to transitions. And I mentioned hospitalization, but also it's very important to mention palliative care. As we know, we are not, when we talk about palliative care, we are not talking about always a terminal situation, an end-of-life situation. And that approach is very important that we can help the families, the patients, even the health professionals to understand that when some patient, when they recommend some palliative treatment to a patient, it can be challenging to understand. So we can help with psychoeducation, with support, and to have a more comprehensive vision and understanding of what palliative care means. The third standard, you can tell me if I'm going too fast, is called mental health attention. And it established that children and adolescents with cancer, along with their families, should have access to psychological, and or psychiatric intervention if needed during all the course of the disease, of course. It focused on prevention and promotion of mental health for patients and their families. This is very important because mental health a lot of times seem like only preventing psychopathology, and it's also promoting mental health. And in this standard, we are including another important things that were mentioned that require specialized care. For example, as neuropsychological assessments or monitoring of the late effects, they need a specialist. So it's included in this standard too. What we found in Peru, caregivers reported that they experienced a stressful event and risk for mental health. And the things that they were asking more help was about the family problems, parenting problems, but they also recall they didn't receive neither their patients or them psychological or psychiatric attention. You can see the numbers here. This is very important because when we make like the contrast with the professional set, the professional said that there was more access that was perceived by the families. Even a lot of families didn't recall meet any psychologist. So that's very important because sometimes, of course, because of the stress of the family, the psychologist, can intervene. But like when we are in a wide room, they don't recognize what are the role of each professional. So that can be important because if they needed more care, more psychological care, they can see where to find who is the specialist there. This standard is also alignment with international standards and health professional perceptions were that improving coping strategies in patients and their family was essential for better adjustment and treatment adherence. So we have to think that if we want the other professionals recommend families and patients to have psychological attention, they need to understand that isn't only for psychopathology, that it can improve coping strategies, for example, different resources. So if all the health team knows about it, it can be a better work. They also mentioned that protocols that include mental health care should be implemented, that it is we have some achievements there, but we need to work more on that. Some recommendation, as I told you, we are also including neuropsychological monitoring at risk cases, especially neurological cancers, prevention and treatment of psychological or psychiatric symptoms, the family support during treatment that requires a specialist of mental health, grief support. We know that a lot of palliative care health members help all the families for the grieving support, but it's important to have also specialists. And as I told you before, promotes mental health also. And the fourth standard, and with this, we end with these big services all children and adolescents and their families should have access to. Here we mean the resources for a gradual return to daily life and support for survivors. So this is including, we need to think that if we can reach high rates of survival, we need to see the patients as probably survivors in a short time perspective. So the resources we want to build in survivors should be developed throughout the course of the disease. As previous standards mentioned, but also in this one, we emphasize in two aspects that are very important during the course of the disease that the patient shouldn't lose. One is the academic continuity and facilitate, of course, the school reentry then, and interaction with various opportunity with peers. I'm sorry, opportunities to interact with peers. And of course, the psychosocial follow-up that can be for survivors that sometimes, a lot of times, here because we are there's a lot of patients that need help. Survivors aren't included in the services hospitals are giving. So what we know that the caregivers report that poor reintegration activities. We know that there are more, for example, hospital school programs, but the families recall they had access to much less. And also peer recreational activities. So this is important because even if there is given more of this, if the families don't perceive it, there's a gap we need to reduce. This is also alignment with international standards, and health professionals said that psychosocial support for school reentry and daily life adaptation should be provided through all the disease process, not only at the end of the treatment. And also the psychosocial care for survivors should be included as part of their health follow-up for survivors. We know that there's a medical one, but psychosocial should be there. But when professionals share these ideas, they were also like trapped because it was like saying, give me more work that I'm capable to do, because we need to recognize that resources are limited. But so what can we do? And one of the suggestions is how can we make alliances with another institutions to start some initiatives that contribute to these standards, document the information, so prove how important it could be. So we need, for example, if we need more human resources, more materials, etc. So some recommendations for implementation are creating hospital environments for play and social interaction. That is lately more common, more colors, more playful environments. Developing playful and educational intervention with patients, implementing hospital classroom programs, providing guidance for school staff. This is very difficult to achieve sometimes, but some institutions said that they could make like sometimes just a little call, but to help the families receive the patients. Organizing survivors support groups, establishing like a flow card to periodic follow-up survivors. And I told you before, to strengthen alliances with existing survivors group and associations, because they can help a lot to identify what are the primary needs of them. Something very important, and survivors reported a lot, is to increase the access to psychological treatment for survivors. So of course, our hospitals is very difficult that they can also integrate all the late effects that the survivor has. But we need to make like a community alliance with different actors, community agents, different specialists, association of psychologists, for example, that can help to give all these interventions that are needed. And of course, increase community awareness about survivorship and about not seeing childhood cancer patients with this pity and overprotective care. They need to recognize it, and we are going to see that in the cross-cutting approach of life course, like children and adolescents that they are. Okay, so we saw the services, as I told you, that should be provided. And now, what are the things that professionals should have? A healthcare professional providing care for childhood cancer must develop psychosocial competencies to offer comprehensive patient management. This is important to interdisciplinary collaboration to have a more humanized and comprehensive care. But it can't be possible if we don't take care of the professionals, if we don't promote self-care and team care of them. So the biggest goal here is to develop the development of personal competencies for self-care. We mean by psychosocial competencies the aspect that they are always teach at what the professional competence with psychologists have. Yeah, but there are some of them that shouldn't be exclusively for psychologists. It should be for all the team to understand the characteristic, the developmental characteristic of childhood, to the psychosocial impact of the diagnosis, the treatment, communicating competencies, etc. So we need to develop these competencies and also improve self-care in professionals. What did we find? Caregivers report, most of caregivers reported that they had communication problems with health professionals. So here, the lack of resources make that sometimes the communication, the treatment is very difficult. They perceive lack of empathy from the professional towards their patients. The health professional, by the other side, reported the efforts to improve psychosocial care were minimally supported and compensated by their institutions. So what sense is they have to continue doing this? Yeah. And high levels of distress and anxiety when managing difficult cases. So with this information, we also know that it's alignment with international standard. Also, professionals in the meetings said that self-care and mutual care are necessary for health teamwork to prevent burnout, to promote well-being. And developing professional competencies can improve the quality of care provided. So if we are, as in this standard, we are taking care of the professionals for their well-being and also the service, the intervention they provide. Some recommendations are training healthcare professionals in psychosocial issues. Sometimes psychological talks are only for the psychologists. So I know a lot of times other members of the team don't get invited or don't go when invited, but we have to try more. Providing self-care spaces for healthcare staff, integrating psychological and psychiatric personnel with the pediatric care team. There was the perception when we asked the professionals, yeah, we work in an interdisciplinary team. Okay, who are involved in this interdisciplinary? And they didn't mention psychologists, psychiatrists, social workers. And the sixth standard is these cross-cutting approaches that we should take, we should consider in all the care we have with patients. So it proposed that it established that the design and implementation of activities under the psychosocial standards should include these cross-cutting approaches. We found 4 that were discussed with the professionals: is rights, life course, intercultural, and gender. And with this, the biggest goal is to have an attention that is inclusive, respectful to differences and particularities, and promote the quality to promote the equity in access and fair treatment to all. What we found, that factors such as health rights for minors and difficulties in providing quality care of access to care due to difference in gender, cultural, and life cycle. That was a lot of, they were very mentioned by the professionals. And these factors, we saw that in previous studies, in educational context, for example, and health context, are included with the term cross-cutting approaches, so we introduce them like that. Just few definitions of each one of these approaches, so you can know what we mean about for each one of them. When life course approach, we include the adaptation of services and interventions that could include the recognition of the cognitive, emotional, and social development that influence variables in the children and also the families that influence in psychological responses during the course of the illness, to adapt the interventions to that. The way that we communicate, the way that we treat, the company that is needed in each stage of the childhood and adolescence. Also, we first call this approach life cycle, like we call it in psychology. But we had this approach that is more like about public health, because something that we found that is very important is to understand childhood cancer as a transition that could represent a turning point in the life trajectory. It means we are not going only to see here and now. We need to see it sometime, but we also need to see the big picture. So we need to make this experience not a traumatic one, not that experience that define the identity and all the life that these patients have later of the disease. So, and the families also. In the intercultural approach, we include the adaptation of services also that includes the recognition and respect for the identity and sociocultural and linguistic characteristic, a cooperative and complementary coexistence in the difference that we can have, health providers and also the families, encouragement of an active role in the disease and treatment process, so that only can be made if we are sensitive to these cultural particularities. A special attention to migration process due to illness that not only lead to cultural differences, but also more difficult to adjust to all the process. And for example, in Chile, they told us that they include sometimes like cultural facilitators, no? Yeah. So there were like, if they have migration of one particular culture, they have one based on an agent that could represent, that could serve like a bridge to communicate and to reduce the gap existing of the cultural gap that could exist. The gender approach was also proposed, especially of all the inequalities we live in our country and our region. It was validated at the region. And the intention is to adapt the services and interventions, including eliminating existing gender gaps, reformulate how healthcare professionals address gender roles, so they can, so the stereotypes they can have according to behavior, emotional expression, don't impact the intervention they make. For example, boys don't cry, the girl should be this way, or the parents, the mothers take better care always than the fathers. So there are a lot of stereotypes or cultural things we have already that can make these interventions not so respectful. We need to acknowledge also the particular impact in illness, so about aspect related to sexuality, and in which each gender have particularities, and inform them correctly. For example, fertility issues also. And of course, prevent and address gender-based violence. The RISE approach is probably the most mentioned, but not always seen like not always we are pointing the most important things. One important thing is to recognize the pediatric patients as subjects of health right, not as objects of care, passive objects of care, but subjects of health rights. They maybe don't have a vote because they are minors, or vote in the biggest decisions, but they have a voice and they can say something. So it involves the respect for human rights and all involved actors, sorry, the consideration also of the context in which services are applied. And this thing is, previous approaches include some rights we already know. But this approach is meant to have not only like a legally view, but a more seem this right as a more inclusive care that we can give, a care that can promote well-being, not only reduce disease but also promote well-being. So to all this information, we have some key recommendations for implementing the standards. Actually, there are some materials that are translating now in English that you can see. We are giving the most important information we found at that time about each standard. And we also, we are making now a guide for implementation, but we give them, we give you with this material, like some easy steps you can follow if you and your institution want to implement this standard. But the biggest key recommendation I can give you right now is the importance to adapt the proposal. I'm presenting you a proposal that started in Peru and is like flexible, because as we see, we need to have clear what is our objective, what is the goal we have. Yeah, but we have to tailor it to fit your institution needs, your resources. So the thing is that you can see what can be each step that you can, what can be one step at a time, I will say here. So adapt the proposal to the needs you have, but to identify the needs and the resources, it's very important to analyze the situation. So assess current needs, resources, like a baseline of how do you start. It doesn't have to be in all the psychosocial care, but maybe you see one of these standards is reflects the more necessity, the needs we have. So we make an assessment about the special needs in that subject, the resources we have to respond to this need. So then we can plan and design an intervention. And the recommendation that is very, very important is to document and evaluate. Don't leave it just in the experience. I know it's very difficult because most of the time when we are intervening, it's very difficult to also document or publish or make investigations, but it's very important to record all steps, to take notes, to evaluate progress, and use this evidence to support the resources that you need. So you say with little resources, it doesn't matter if you start with a short population or just a very specific need, but you document it correctly, and then you can see what can you do if you have, for example, more resources, but based on evidence, because sometimes to have more resources, to be more heard, we need to say what are we doing, and we sometimes don't prove it correctly. Well, and design, execute after all this communicator a detailed plan that can be followed by the team that you establish, and that could adjust conformity, like make it like a pilot plan, yeah. So you can see what are the short-term goals you can achieve, and then think of the next one. This is a summary of the things I've already told you, but to remember some things of the project and tell you about the biggest achievements that are the proposal of the 6 standards. We had more than 17 published materials, most of them in Spanish. We are going to share with you some of them. We are translating them to English. The big participation we have for the healthcare professional. This was in Peru first, but now we have more than 100 of professionals interested in the project in Latin America and Caribbean. And in progress, well, here you have also you can scan this QR to access to the paper that is very detailed what we did on the project. And now, well, we are running the situational analysis at the regional level. We want to implement and evaluate in focal points. We have focal countries that want to document what the way that they can implement those standards. And we are creating a toolkit for standing implementation. So in this, I want you to invite you to share. We need to share between all of us, what are we doing? What are we doing good? What materials do we have? And improve them with like a big work team. Yeah, so we want to make like a toolkit that every professional, every country can get access to. Okay, what can I do for contribute to this standard? Let's see what that country what is doing, that institution, make that video, that material, and that is going to be very important to strengthen the psychosocial perspective for all of us. These are you can scan the links, the access to these materials. I'm going to pass you also in the chat so you can have it. We had the article, we have these modules I told you, a brochure, videos in Spanish. And here is another work that was made by the multi-center group I told you about in Peru, contributing to school reintegration. They make story tales to teachers. That was to help them understand what were the biggest challenges children with cancer had, and how can they talk with the rest of the children, and when she returned to the school, what things should be done. Yeah. So, well, thank you very much. I hope that you could understand my English, and well, very happy to hear your thoughts or recommendation for this.
Thank you so much, Viviana. This was indeed a very insightful and very informational session. If any one of you have any questions to ask, I think we can take on some questions. And In the end of the slide, I think Viviana has also shared her mail ID. So if you have any more specific questions to ask to her, then maybe we can also mail her.
I'm going to copy it in chat.
And yeah, thanks, Amelia. I think we have covered most of the things in this session, and we have already given a lot of time. So thank you so much, Viviana. I think we will end this session here. And if any one of you have any more questions, Viviana has shared her mail ID with all of us, so we can just mail and ask if anything else needs to be discussed.
Yes, thank you very much.
Thank you.
To all
Thank
of
you so much, Viviana. Thank you everyone for joining in. And once we have the recording, we'll be happy to share it in our WhatsApp group as well.
Thank you very
Thank you very
much.
much.